Hey everybody, this is Shannon Finks with the Finks 5, and today I have with me DJ Barrow, who's a fourth-year pharmacy student.
Today I'll be presenting my Finks 5 on sulfonylureas. We've been talking about diabetes agents, and sulfonylureas are not used often. There are a few things you need to know to keep patients safe with their prescribed regimen. So we will talk about sulfonylureas' role in therapy, commonly used agents and their pharmacokinetics, why you might still see sulfonylureas being dispensed, and more importantly, the risk involved so you can communicate them to your patients. We will summarize where they fall into the diabetes standards of care treatment and give you some tips you can share with your patients. This is the beta cell within the pancreas. Sulfonylureas bind to sulfonylurea receptor 1 on functioning beta cells. This results in decreased influx of potassium due to the interaction with potassium sodium channel ATPase and depolarization of the beta cell membrane. This depolarization causes calcium to enter the cell through voltage-dependent calcium channels and ultimately results in the increased release of insulin. This class of drugs is also known as secretagogues because they increase the secretion of insulin. Each year, the American Diabetes Association publishes a living guideline on the standards of care in diabetes. The red box highlights where sulfonylureas are located within the treatment algorithm. This will be discussed further. Metformin is the basis of all type 2 diabetic patients' therapy, unless it is contraindicated. Sulfonylureas are options that can be added to therapy if the patient does not have high risk or history for atherosclerotic cardiovascular disease, chronic kidney disease, or heart failure, and is not at goal. The goal for each patient should be individualized. More stringent goals are for patients who are otherwise healthy, and less stringent goals for patients at high risk for hypoglycemia and other comorbidities. Other oral agents are often used before sulfonylureas, but a sulfonylurea is an alternative if cost is a major issue. The most prescribed secretagogues are glyburide, glipizide, and glimepiride. These are the second generation sulfonylureas and are used most often due to their increased potency when compared to the first generation. They are given either daily or BID. Glyburide has two available formulations. The micronized formulation has an elimination half-life of 4 hours versus 10 hours for the regular formulation. This is to decrease the potential for hypoglycemia, which this drug class is notorious for causing. Glipizide also has two available formulations. The extended release formulation is dosed once daily. Glyburide should be avoided in renal impairment, while glipizide and glimepiride can be used at lower doses. For hepatic adjustment as a drug class, sulfonylureas can be used at lower doses in patients with Child-Pugh A and B scores and should be avoided in Child-Pugh C score. Next, we'll talk about dosing titrations for the different sulfonylurea agents. The first agent we'll talk about is glyburide, also known as diabeta, or the micronized version, micronase. Glyburide and micronized glyburide are not equivalent. Retitration is needed if switching between the different products. Now, if a patient is being converted from insulin to glyburide, there are important points to note. First, if the patient is taking up to 40 units daily, discontinue the insulin and initiate glyburide. There are no transition periods required. If the patient is taking greater than 40 units daily, there is a transition period required. First, you will reduce the insulin dose by 50% while initiating the glyburide. You can initiate the glyburide at 2.5 to 5 milligrams by mouth daily. Titrate in increments of 2.5 milligrams weekly. For a maintenance dose, it can be between 1.25 to 20 milligrams by mouth daily or in 2 divided doses. The max daily limit for Glyburide is 20 milligrams a day. The next dosing titration we'll talk about is for glipizide. For the immediate release formulation, it's also known as glucotrol, and for the extended release formulation, it's glucotrol XL. For the immediate release, you will initiate at 5 milligrams by mouth daily before breakfast. Increase in 2.5 to 5 milligram increments weekly. For the immediate release formulation, the max daily dosing is 40 milligrams daily. In doses greater than 15 milligrams should be divided into 2 daily doses. For the extended release formulation, you'll initiate at 5 milligrams by mouth daily before breakfast. Increase by 5 milligram increments weekly. The max dosing for extended release formulation is 20 milligrams daily. The next dosing titration is for Glyburide, also known as Amaryl. You'll initiate at 1 to 2 milligrams by mouth daily. Increase by 1 to 2 milligram increments every 1 to 2 weeks. The max daily dosing for Amaryl or Glyburide is 8 milligrams per day. For sulfonylureas, you want to make sure to increase only when necessary. Make sure the patient is tolerating the regimen and has a clinical response as therapy continues. As a class, they are known more for their risk than their benefits. The major risks for sulfonylureas are weight gain and hypoglycemia. Patients can also experience other annoying side effects such as rashes, headaches, GI symptoms, and beta cell function loss. There is a potential for SIADH, or syndrome of inappropriate antidiuretic hormone, but it is a rare occurrence. This syndrome causes patients to retain sodium and fluid due to decreased renal excretion. Patients with SIADH will report symptoms of nausea or vomiting, memory impairment, confusion, seizures, and they may experience a coma. Please educate your patients on this and make them aware of any intolerable side effects to discuss for future therapy. If you see them used, it's because they are cheap, they may affect both fasting and postprandial glucose, and have an A1C reduction of 0.8%. In summary, sulfonylureas are not commonly used and are not recommended as first-line therapy, but they do have a role when patients cannot afford other agents. The main adverse effects are weight gain and hypoglycemia. Make sure to communicate with your patients about the risk when they are prescribed sulfonylureas.
Thanks, DJ, for preparing the Finks 5, and a special thanks to Dr. Jennifer Campbell for her peer review of this session.